And welcome to the voice thread for the hip unit. Structures that will be discussed will include the femur, innominate, the labrum, the ligaments of the hip, musculature surrounding the hip, arthrology of the hip joint and the pubic symphysis, and osteokinematics and arthrokinematics of those joints. And we'll kick it off with the femur here. This is the longest and strongest bone in the body. Here in this image, we can see the proximal end of the femur. Here we have our nice, dense cortical bone and our nearly cylindrical shaft. And if we were to look at the tibia, so if the tibia were down here below, we would see that this bone is inclined upward and outward relative to the tibia. The femoral head in the normal anatomic position, this is going to face in the anterior, superior, and medial directions. It's a sphere-like, not a perfect sphere, hence spheroidal. And a nice smooth articulation surface there with the exception of the little fova here for attachment of the ligamentum teres. And this is the proximal femur. Here we can see a posterior view, so the femoral neck allows us to have a greater degree of motion without bumping into the pelvis as we go through in ranges of motion, while still allowing us to have that nice larger contact area of that spheroidal femoral head. Now the capsule is going to extend in the posterior aspect to about the mid neck, but in the anterior aspect it's going to go to the intertrochanteric line. And here we have the greater trochanter. This is going to project in a superior medial direction here. The lesser trochanter, this is going to project posterior medially. And these are going to serve as nice attachment sites for musculature of the hip here. The intertrochanteric line we can't see from this posterior view, but it would be on the other side connecting the greater trochanter and lesser trochanter. Our intertrochanteric crest here we can see in this posterior view. This is going to be a ridge for attachment here between the greater and lesser trochanters. So again, that femoral shaft here with our nice, dense, compact bone. We have an intermedullary or a medullary cavity there within, and this is basically going to be a columnar shape here, and this is going to help sustain compressive loadings. So loadings from the body weight here with different activities, but also we've got these ridges here that are going to basically be those attachment sites for those strong muscles of the thigh here. So our linea aspera, medial and lateral lips here, and so this is the distal end of the femur here, a inferior to superior view. We can see the medial condyle, the lateral condyle. Anteriorly, we have this patellar surface here. This is where we're going to have that nice area where the patella fits in nicely, so it'll stay in that groove during flexion extension movements of the knee. We've got our intercondylar fossa here. And here we can see with this medial condyle how we have a bit of a curvature. With this being medial and this being lateral, we would consider this a medial convexity, in other words. Also on our condyles, we want to note these epicondyles, these eminences coming medially here at the medial epicondyle and lateral here at the lateral epicondyle, which are going to be important attachment sites when we get into musculature and ligamentous structures. And this slide is a reference slide for you to gain an appreciation of, from this posterior view, that is, the attachment sites of different musculature surrounding the hip here. And here the anterior view, we can see the attachment sites. And our angle of inclination, this is the angle of the femoral neck relative to the femoral shaft. So in an adult, typically this is going to be about 135 degrees on average, though anything ranging from 125 to 140 is considered normal. Anything less than 120 degrees is going to be considered coxa and anything greater than 140 degrees is going to be considered coxa. So the angle of anteversion, this is that normal torsion that occurs in the transverse plane. And if we were to extend a line through the femoral neck and at the posterior-most aspect of the femoral condyles, we would expect that normal angle of anteversion to be about 10 to 15 degrees in adults. And here we can see that femoral head approaching in the superior, medial, and anterior direction. Again, our normal anteversion. Retroversion here, 5 degrees. We can see this abnormality. Excessive anteversion, about 40 degrees, can be problematic as it can predispose a patient to anterior dislocation of the hip. Also, it leaves that anterior femoral head a bit more exposed than it normally would be in a resting position. Also important to note that abnormal angles of anteversion can alter the position of the lower extremity relative to the pelvis. And in the anterior view, we can see the lateral circumflex artery. In the posterior view here, we can see the medial circumflex artery. These are going to ascend up the femoral neck, also supplying blood to musculature of the hip, but they're going to ascend up the femoral neck. And from a clinical perspective, it can be important if we have that fracture of the femoral neck there, as they're important for blood supply to the proximal femur, so that avascular necrosis being of concern there. And in childhood, there's also arterial supply within that ligamentum teres as well. I'll talk about that on a subsequent slide. And on to the innominate. And here we can see that superior pubic ramus, that inferior pubic ramus, or pubic tubercle, we can see right here. Those nice attachment sites. Additionally, we can see our body of the pubis right in there. And the ASIS, the PSIS, the iliac crest, the gluteal surface here. Here we can appreciate that iliac fossa as from our previous slide, but now getting into the ischium, we can see the body of the ischium here. We can see that ischial ramus, the ischial tuberosity down here, the ischial spine, and we note these structures from what we've talked about with ligamentous attachment from the SI joint, and we also know, of course, the structure that we're going to want to purchase on for our SI joint mobilizations that we've been over. So angles to note for the acetabulum, our angle of inclination. If we were to look at the line between the most prominent ridge of the acetabulum on the superior and inferior aspects, we would expect for a line of about 45 degrees of inclination there. Additionally, if we were to look from anterior to posterior, we would note that the line between that medial and lateral most margin of the acetabulum compared to an anterior to posterior line, we would expect about 14 degrees in men, about 19 degrees or so in women. This is also going to come into play when we're talking about stability of the hip joint, but noting that angle there of about that 45 degrees where it's going to articulate nicely with the head there. So in other words, we're going to have some bit of an overhang here where that femoral head is going to be able to be nice and stable there in the acetabulum. So we've got different spaces, canals, foramens formed by different parts of the pelvis and the femur, formed by interaction between different ligamentous structures and osseous structures. Quickly, this is a structure or a space that we'll talk about more in depth coming up soon. But the gap between the inguinal ligament and the pelvic bone here, we're going to have vascular structures, the femoral nerve, different muscular structures, different lymphatics that we'll talk about. Our sciatic foramen, greater sciatic foramen in terms of above the piriformis and below the piriformis. Think about the neurologic structures passing through these spaces. So our sciatic nerve, our nerves to the obturator, to the inferior gemellus. So we have different structures that are going to be passing through there that we'll talk about, but think about different things that might be impinged within. Also our obturator canal, think about the obturator nerve, the obturator vasculature passing through there as well. Alright, so our space between the inguinal ligament and the pelvis, so we can see that inguinal ligament here, the pelvis here. So a good way to remember these is navel, so NAVL. We've got the nerve, the femoral nerve that is, the femoral artery, femoral vein, and the canal here where our lymphatics are going to be housed. So in other words, A, artery, V, vein, L, lymphatics. So we've also got our iliacus muscle here. We can see the psoas major muscle and our pectineus muscle as well. And here in this picture we can come back and think about that artery that is typically present in younger years there, so where we've got vasculature coming through that ligamentum teres to vascularize the head of the femur. So we have a lot of different things that are going to aid in stability of the hip here. So of course that bony congruency, that contact area of the articular surfaces being described as about a half a sphere on that articular head, on that femoral head there. The labrum, which is going to be an expansion of that acetabulum, or a fibrocollagenous expansion there. It's going to help with stability, our vacuum effect. So we basically get a vacuum in between the two structures there. And cadaveric studies have been performed where different soft tissue structures were severed, and that femoral head is seated nicely there within the acetabulum. Our thick capsule is going to help out a lot. We'll talk more about that. Our strong ligamentous structures, which we're getting ready to get to. Transverse ligament of the acetabulum, so also improving that full seating of the head there in the acetabulum. Our joint angles that we've already talked about to a degree, pardon the pun, and our muscular stability that we're going to have from the many muscles of the hip. So our arthrology of the hip, we've got our nice spheroidal femoral head, so not a perfect sphere, but spheroidal, perhaps slightly ovoid. There's going to be some variation from person to person. We've got that nice lunate-shaped acetabulum, where we're going to have that pelvic articulation, that is. Now, not a complete ring, but we're also going to have that transverse ligament that's going to, transverse acetabular ligament, that is, it's going to complete that structure there. So again, noting that when we're looking at the acetabular component of the hip and the femur and the head, we're thinking about that nice angle of the overhang here. So in other words, we've got basically a setup where gravity, when we're in a standing position, is going to help push that femoral head right on into that acetabulum. So onto the hip labrum. This is often described as that triangular fibrocartilage structure here, and we can see this fibrocartilage here, and also the dense connective tissue, so commonly described just as fibrocartilaginous, but there's also some dense connective tissue. Basically, this is going to help widen the surface area of the acetabulum there where the femoral head is attached, and it's also oriented to be able to accept compressive loading there within the joint. So in other words, compressive loading between the femur and the pelvis. Just to explain one of these images a little bit better here, we see the joint capsule, that is, as it's connecting onto the labrum, and a slight fold there, in other words, and this would be subchondral bone here. So where do we actually have vascularization? In other words, greatest potential for healing our outer third of the labrum, essentially. The inner two-thirds being thought of as avascular, and clinically this translating to a decreased potential for healing. Innervation, we're thinking proprioceptive input as well as nociceptive input, so pain information as well as that important proprioceptive function. And on this picture here, we can see a common way that the labrum is referred to. So when reading surgical reports, this can be really handy to know our clock terminology for our labrum. So 12 o'clock being that superiormost aspect, the 3 o'clock position, so that 12 to 3, the anterior superior aspect of the labrum there, 3 to 6, that anterior inferior, 12 or 9 to 12, that posterior superior, 6 to 9, that posterior inferior. And the joint capsule, this is a very strong and dense structure here. It's going to be the thickest in that anterior superior aspect there. Again, vascularized and carrying vessels up to the femoral head, neck, labrum there. So strengthened by ligaments of the hip, which we're going to get into very shortly. And also remember what we talked about previously. So from this posterior view, we can see how it comes to about mid-femoral neck, and in the anterior view, which we don't have here, we would see it coming down to that intertrochanteric line. So here we can see that inverted Y ligament, that iliofemoral ligament. Basically, this is going to come down to provide anterior stability to the hip there, especially when we're in that extended position in the hip. And this is going to connect between the ASIS and the acetabular rim and come down into the anterior trochanteric line we can see anteriorly. And here we see that pubofemoral ligament, which is basically a triangular ligamentous structure there. And our iliofemoral ligament here, so we've got 3 parts to this, our central, and we've also got, here you can see the lateral and medial most portions of this, and basically they're going to help wind around that femoral neck as well. And this is just a bigger view here, so again that inverted Y, that iliofemoral ligament, our pubofemoral ligament, we can see that triangular structure, and the central, the lateral, and the medial portions of our ischiofemoral ligament. Now with extension motion, so as the hip is put in an extended position, these ligaments are going to wind around the hip. So all of these ligaments are going to become tautened and essentially provide stability to the hip joint itself. Now with flexion, the opposite occurs. So these ligaments unwind around that femoral neck and become slackened, With adduction, that's abduction, our iliofemoral ligament and our ischiofemoral ligaments are going to become tautened, whereas our pubofemoral ligament is going to be slackened. The opposite occurs with abduction, that is. With external rotation, our anterior bands or anterior ligaments are going to become tautened, and with interior rotation at the hip, medial rotation at the hip, that is, the posterior ligaments are going to become tautened. And apologies, that is internal rotation, not interior rotation, when referring to medial rotation. And this is just a written summary of what was discussed on the last slide for your reference. And here our transverse acetabular ligament, again connecting that anterior and posterior most aspect of our lunate shaped acetabulum, and being that completion inferiorly the acetabulum there. And underneath there, we're going to have the entry of vascular structures, nerve structures. So our ligamentum teres again here, basically this is thought to be most tensile position of flexion and adduction, so slight flexion and adduction, and slackened in abduction, that's abduction. So when we're talking about testing internal and external rotation, range of motion, think about the difference that we might expect to see between having the hip in a flexed position versus a neutral position. In other words, testing in a 90 degrees of flexion, we would expect basically a slackened position, whereas when we're talking about testing in prone or in a neutral position, we're going to be expecting basically a more taut position there. Just a review slide here, so thinking about pelvic tilting, again, the component of motion at the lumbar spine and at the hip, thinking about our hamstrings, those posterior pelvic rotators, the glutes, the anterior abdominal muscles, thinking about our anterior rotators, with that iliopsoas there, our rector spinae, rectus femoris. And getting into hip musculature now, so our psoas minor, which we can't really see in this picture, being absent about 40% of the time actually, and this is going to be anterior to that psoas major that we've talked about, and it's thought to be a weak flexor of the trunk potentially. So our iliacus, basically going from that iliac fossa there on down and blending in with our psoas major. So basically a strong component of hip flexion, and though it's thought to be described as a medial rotator or an internal rotator, long story short, that is debatable, and we actually see some activity in external rotation with this muscle. And our sartorius, our Taylor's muscle, in other words, is cut here. But basically this is going to be a muscle that's going to help out with some flexion there at the knee and also at the hip. It's going to help with abduction, that's abduction, and external rotation as well. Basically the longest muscle in the body we can think about, that's the claim to fame there. It's going to come down and blend with the gracile and the semitendinosus down there at that pes anserine, or the goose's foot, pes anserine. And here we see the proximal portion of the rectus femoris, and that muscle is going to come off of the AIIS and insert along with the rest of the quadriceps there to the patellar tendon. And the gracile is going to be coming down from the aponeurosis there at the pubis and the ischioramus into that goose's foot down there, again blending at the pes anserine. This is going to help out with flexion and internal rotation at the hip there, and also thought to potentially be a bit of an adductor at the hip. So the tensor fascia lata here, this is a muscle that is going to come down and insert into that IT band. It's thought to go about a third of the way down that thigh distally, but sometimes, long story short, it can extend a little bit further. But this is thought to affect knee motion when we're an extension of the hip more so. And additionally, the status as an abductor of the hip is a bit debated at times, and also described as an internal rotator of the thigh. So here we can see the pectineus well. This is as it sits deep to that inguinal ligament there, and this is going to be an adductor and flexor of the hip. We can see it in this picture as well, right here. Also our hamstrings we want to talk about a little bit. We'll get a lot more to it when we get into the knee, but not only are the hamstrings extensors of the hips, but when we have a slightly flexed knee, we can get medial and lateral rotation, or internal and external rotation of the tibia relative to the femur, which is a motion that's commonly overlooked in most examinations, and really we want to think about the function of those hamstrings as tibiofemoral rotators and stabilizers as well. Alright, and the adductor group here, we see the adductor longus, or where it's been cut here. We can see our adductor brevis as well, our adductor magnus. So long story short, these are going to help out with synergy and gait. So in other words, not necessarily providing that active adduction force so much as a synergistic muscle. The longus is going to help with flexion of the hip, and the magnus is going to help with some extension of the hip as well. And our gluteus medius here, certainly a very, very important muscle when we're talking about stability of the hip. So when we're in unilateral stance, let's say on the left leg in this case, basically our center of mass is going to shift a bit laterally compared to midline, and this gluteus medius is going to help keep our pelvis level. So contraction of that gluteus medius is going to help keep our pelvis from dropping down on the other side. And just for clarity's sake here, abductor of the hip and internal rotator of the hip. And this is a posterior view of deep hip musculature. So here the gluteus minimus, our abductor and internal rotator of the hip as well. We can also see our gemelli brothers, our superior gemellus, inferior gemellus, separated there by the obturator internus, helping with hip stability there. Also potentially the external rotators of an extended hip, and abductors of a flexed hip, that is quadratus femoris, basically an external rotator of the hip there. Our piriformis we can't see here, but we'll get there. We can see that piriformis, and this is going to be our external rotator of an extended hip, or an abductor of a flexed hip. And in this anterior view, we can see the obturator externus, which would be a lateral rotator of the hip, and also counters hip internal rotation. So as a force couple, that is. So a good resource here, just mapping out of different lumbar nerve root distributions of the different muscles, so also by movement. We can look at hip flexors and go straight into the different innervations here. So again, looking at which nerve structures innervate, and additionally going further into nerve root. Take some time to look through these. And you can find this in a handout that was posted under the lumbar spine unit as well. So here we can see different sensory distributions, some more of the dermatomal distributions, dermatomal mapping, which will come into play a little bit more so when we're talking about examination. And here we can see some of the cutaneous distributions here mapped out. So when we're wanting to think about peripheral nerve injury versus nerve root injury, which we're going to talk more about in the examination lecture, remember these images. So to review the sciatic nerve, it's going to come from the fourth lumbar nerve root through the third sacral nerve root, and it's going to go deep to that glute max and rest on the posterior ischial surface there. And typically it's going to come underneath the piriformis. However, there can be anatomic abnormalities where it pierces through the piriformis, or it splits off and partially goes through the piriformis and underneath the piriformis. And it's going to descend between the greater trochanter and the ischial tuberosity. And coming on down, it passes deep to that long head of the biceps femoris tendon, which is another area where entrapment can occur of that sciatic nerve. And at about the lower third of the thigh, it's going to split off into the tibial nerve and common fibular nerve, although there can be some anatomic variants such that it'll split below that, lower that is. And osteokinematic motion. So flexion and extension, there's going to be greater motion passively than actively. So active flexion about 120 degrees, passive flexion about 145 degrees or more, active extension about 20 degrees, whereas we get about 30 degrees or more passively. Internal rotation, external rotation, abduction, and adduction, all going to stay about the same from active to passive. So internal rotation about 30 to 40 degrees, external rotation about 45 to 60 degrees, abduction, that's abduction, about 45 degrees, adduction, that's adduction, about 30 degrees. Resting position of that hip is going to be about 30 degrees flexion, 30 degrees abduction, slight external rotation, and our closed pack position is going to be full extension with some abduction and internal rotation as well.